into a doctor's office, and I'm not the doctor, and I see a loved one who's either their partner or their wife, or their sister, or their daughter, I usually know that that man is coming back and that he's going to do the right thing because he's got someone in his life. Your friend, your brother, your neighbor, someone in your congregation, and say, hey, how's your PSA doing? Or how's your prostate going? Did you get checked this year? Or are you going to get checked? And to keep each other, that kind of, it's also about how we go about our lives. James, thank you for allowing us into your congregation on all the different levels. So thank you, sir. And so Kim, thank you for ordering Eugene, Alfonso, and the doctors that I'll introduce now for their time. And I think you're going to hear some really powerful messages today. So the doctors that are going to speak to you will be Dr. Gina Engel, who is a primary care physician here at UVA, and also Dr. Christine Billabor, who is a urologic surgeon with a specialty, and then Mr. Alfonso Taylor, who many of you may know personally, is going to share his own personal journey with prostate. Don't be bashful, don't be shy.
Thank you for having me, and I'm trying to figure out the best way to do this. I'm going to actually stand up because I have to move while we're talking, so I'm going to just go right over here. We're here to talk about prostate cancer, and I'll tell you that we're going to talk about what the prostate is and where it is, right? I think most of you kind of know, but it's a little bit weird, so we should start there. And then we'll talk a little bit about what does the prostate do, what is prostate cancer and why should you care, who gets prostate cancer, how do you prevent it, and then what difference does it make if you have a primary care physician, right? Thank you. So what is the prostate, right? So the prostate is this little gland, right? It's part of the male reproductive system, and it secretes fluid, okay? When this prostate gets enlarged, right? We've all heard about prostate enlargement, or people who have to run to the bathroom more frequently at night, or some of those sorts of things. Why does that happen? Well, as you can see, as this prostate gets a little bit bigger, it can press on this tube that passes through from the bladder out through the penis, and that's where you empty your bladder. So as that prostate gets bigger, it pushes on that tube, and then it's harder to get the urine out. And that's why sometimes people will have a hard time starting urination, hard time stopping. They might not empty the bladder all the way, those sorts of things, right? The fluid that the prostate secretes is part of what's in the ejaculate. And so that's one of the reasons that, you know, like, why do we even have a prostate? Only men have a prostate, obviously. But that within that fluid is this prostate-specific antigen, the PSA, right? So that's what you all hear about measuring. So when we do sometimes a prostate exam, the only part of the prostate that we can feel is that one edge that pushes up against the bottom. And that's why we have to do this with a gloved finger through your bottom, right? I mean, we're here to talk about the prostate. We have to talk about the good and the bad and the ugly, right? But that's the one area that we'll sometimes look to feel if there's a nodule, like are there little lumps or bumps, or is it enlarged? Some people will kind of talk about that the prostate is a donut around that urethra or around that tube, and that's what they're kind of talking about, again, that gland sits around that. So who's at risk for prostate cancer? I mean, some of these are kind of obvious, but I think they're clear. You know, all men are at risk. So just out of the gate, if you're male, you're at risk for prostate cancer. The older you are, the more likely you are to get prostate cancer. We almost never see this in people who are less than 45. The most common age at diagnosis is 66 years old. And you are at more risk if you're African American. And I don't know if we completely understand that, because naturally that does seem to be the case. But there are some things that we're trying to correct which are at play as well. African Americans tend not to be as likely to have a regular doctor, and so the regular checkups might not be as frequent. And so again, those are things within UVA Health and within our communities that we're trying to address. Even things like insurance aren't as common, or some of the costs for healthcare might be different. And those are things that, again, UVA is looking to see what can we do to make those things not a barrier. Also, having a family history puts people at risk. In my family, I've heard other people talking. My dad has had prostate cancer. His was aggressive enough, he had to have surgery. But he had many options. He had to talk to his doctor about kind of what were the pros and cons of various things. My grandfather died with prostate cancer, but that's not why he died. So again, strong family history. My grandfather got this when he was older, but other things were also a problem. So again, I think common stories that you're hearing here. What puts you at risk as far as family history? And actually, I see them having a little trouble with the volume. Is this any better if I take my mask off?
Yes.
Okay, let's do that. Sorry. So other things that put you at risk are, how much family history is an issue. Certainly a first-degree relative. So dad or grandfather can be a risk factor, but not as much. A brother having prostate cancer definitely puts you at risk. If somebody was diagnosed with prostate cancer when they were younger, then your family history is going to be a little bit stronger. The same is true with breast cancer for women. And then finally, if you also have other people in the family with other kinds of cancers, sometimes that can put you at risk as well. Particularly if family members have breast, ovarian, or pancreatic cancer. So again, just some kind of common facts. Prostate cancer is one of the most common malignancies or cancers in men, behind skin cancer, which, as you can imagine, is very common. About 1 in 8 will be diagnosed in their lifetime. We talked about the age. Death from prostate cancer is a leading cause of cancer death. But one of the things I'll tell you is it's really common to be diagnosed with prostate cancer and never have to do anything about it. So that's the one thing too to kind of know, is that you shouldn't be worried about getting screened, that you're going to find out something really bad that you can't do anything about it. The more that we screen and catch things earlier, the better that we can do something about it. There's also many times that with prostate cancer that we'll find prostate cancer and we don't have to do anything for a long, long time or ever. And so when you hear that, it's not because somebody's doctor's not paying attention or something, but some of these are so slow growing that they're not a concern. But that's why you do need to kind of follow it. So what is prostate cancer in general? Cancers are when those cells grow out of control compared to others, and those cells, if they metastasize, that's when they go other places and give you problems. So again, just some kind of basic things to be aware of. Prostate cancer can do that, but we don't see that as often. Usually, again, it's slow growing, it stays fairly local. It can spread quickly, but that's, again, not very common. As you see, 3.1 million have been diagnosed with it, but many of those are living with it. We talked a little bit about kind of the increased risk for African American men, twice as likely to get prostate cancer than other men, twice as likely to die from it. Sometimes that's because it's more aggressive, sometimes it's because we found it later, which again is why the screening becomes important. So now I've told you all these terrible things about prostate cancer, and you're probably like, oh, great, now what? So let's talk about the now what. What can you do? Well, there's a few things we can do to try to prevent it. You can't do anything about your family history, so we're not going to focus there, right? You're male, you've got a prostate, can't do anything about that. However, healthy diet and keeping your weight in check do help. So more fruits and vegetables, watching things like processed meats. So when I think of this, I think of all the really good things, right? Bacon and pepperoni and that sort of thing. It doesn't mean you have to be perfect. We're talking about limiting things, being aware of it, you know, again, trying to keep that weight in check. Exercise also helps. And then seeing your doctor regularly and having the conversation. Do we check people's prostate every year? Sometimes. Sometimes we don't anymore, and sometimes we're a little bit, you know, we like to have a conversation about PSA before we just do it. So that's the screening for prostate cancer. And when I say screening, what we're talking about is we're going to do a check to see if we can catch that prostate cancer or other problem earlier. For prostate cancer, it's really pretty simple. The PSA is probably the best test. The problem is that the PSA is not perfect. The PSA can be elevated and not mean much, right? It can mean that it's enlarged. So the conversation that I generally have with my patients goes something like, well, what is your family history? Are you having any symptoms? And then what are we going to do with the information so that you don't see a number and then go, okay, now what? If that number is a little bit elevated, if you're not having problems, if you don't have a real strong family history, oftentimes we'll recheck it or we'll follow it, check it in 6 months or a year, that sort of thing. If the number's high, again, we don't just kind of all of a sudden go, oh, that's it. No, sometimes those can actually even be false positives. Sometimes over time those will come down. I think Dr. Billibor will talk to you a little bit about other things that will elevate the PSA. But again, those are the reasons that we want to kind of be aware that, you know, we don't have to necessarily chase that number down every time. The other thing we do, of course, is that digital rectal exam, and that's that check of the prostate within the office. Again, it's an okay test, but not great. We tend to do it probably every other year, but we don't even have to do it that much anymore, especially if people aren't having symptoms. So again, it's a conversation of what are your risks and what are the best tests for you. So why a primary care doctor? Well, a couple of things, and I'm biased because I'm a primary care doctor, but we think that we like to have a relationship with you. We know what the risks are for prostate cancer, we know about various things, but when you and I are in the office together, we can have a conversation and we can do what you need, right? Everybody's needs are a little different, sometimes their wants are different. What you want to do at 45 years old and what you might want to do at 80 years old might be different, and that's okay. And that's why we want to get to know each other and kind of make decisions that are best for you. It gives you a medical home. If you have other medical things, we follow those. We keep track of your health history. I'm going to look at my friends who are specialists. We translate for the specialists. So when you go see some of your specialists and you come back and you go, I don't know, they told me a whole bunch of stuff and I'm not sure. Well, I get to help translate that, and it's a fun part of my job to make sure that you understand all the different things that are going on. It can lower your healthcare costs to have a primary care doctor because in an ideal situation, we should be available for you to answer questions so that you don't have to go to the emergency room unless you really need to. We like to try to have appointments so that if you have a sore throat or a sprained ankle or just a question, that you have somewhere you can get those things addressed. And so we know that in this area there's quite a few primary care doctors. Unfortunately, I think we need more, And so that is one thing that UVA Health is working on. I don't know where we'll put these doctors. I don't know where we'll get them all. But I know as we continue to grow within this area, that is an area that's of concern to us, and that we're looking at. Now, I wouldn't be a very good primary care doctor if I didn't just tell you about a couple of other screening things that we should address. So prostate cancer, although fairly common as cancers go, is not as common as other things like diabetes and kidney disease and high blood pressure, all of those things that put you at high risk for heart disease. And so again, I really encourage each of you to have a doctor that you know, that you can go in and feel comfortable with. And, you know, while we're talking about prostate cancer, we can also address these other things. And colon cancer is also a really preventable disease that, you know, if we can talk to each other and get you screened at the right time, that hopefully we can make a difference in all those things. So that's the last slide I have for you. I'm going to let Dr. Billibor give you some information, and then we'll do some questions at the end. So thank you so much, and we'll go from there.
Good morning, everyone. I'm Christine Billibor. I'm a urologic oncologist at UVA, and I'm kind of discussing a little bit more of the granular details about prostate cancer diagnosis, signs and symptoms, and then the different treatment options. So typically, most men who are diagnosed with prostate cancer don't actually have symptoms at all, because prostate cancer typically is diagnosed very early and it's too small to cause any symptoms. As Dr. Engel said, the prostate is below the bladder and circles the urethra. So for a tumor to be big enough to cause symptoms, it would have to be pretty large. So most of the time we diagnose these cancers by PSA alone. And again, like Dr. Engel said, the PSA can be high for other reasons. Infection is a common one. Having an enlarged prostate, PSA is something that is produced by all prostate cells, even cancer cells. Cancer cells just make a lot more. So there are a lot of different reasons why your PSA can be high, but typically when we diagnose prostate cancer, it's usually from men. And about 3 to 5 is around the level of considered elevated. But typically we may have to repeat that, and as she said, 6 months to a year to make sure that the elevation is not from something else. So prostate cancer is diagnosed by doing a biopsy. A biopsy involves taking a small pieces of the prostate through a needle. And this is typically done under ultrasound guidance. An ultrasound probe, just like, you know, when we have an ultrasound for a baby, we put an ultrasound through the bottom, close to the prostate to visualize it and take small little pieces. Sometimes we can get imaging studies before the biopsy that can look for areas within the prostate that may be concerning for cancer, and those areas can be targeted by an ultrasound guided biopsy at the time. Prostate biopsy is typically done in the office, a short procedure that takes about 15 minutes. It's a little bit uncomfortable, but typically it's very important. And most people are a little bit more afraid of it than it is, and most of the time it's not as bad as people think. So, and after you get a prostate biopsy, you'll be given a pathology report. If there is signs of cancer, it'll tell you the number of pieces of the prostate tissue that was taken at the time. Typically that's 12 to 14 pieces, and it'll give you the number of pieces that actually have cancer in them and the portions that don't. And then the biggest important thing about prostate cancer diagnosis is knowing the Gleason score. So Gleason was actually a pathologist. He studied a lot of prostate cancer cells under a microscope, and he gave them a scoring system that for which it's named under him. And it gives you 2 numbers. The first number is the primary pattern. Primary pattern just means the majority of the cells within those pieces and what they look like. And then the secondary pattern. And then you get an overall score, which is the sum of both of those. Now the primary and secondary pattern are graded from 3 to 5, with 3 being the lowest grade and then 5 being the greatest grade. And then those numbers are added together to get your overall score, which is rated from 6 to 10. And the lower the number, the lower the likelihood that the tumor or the cancer is going to spread or has already spread. So this is just kind of the different scores that you would see on a pathology report. So 3+3 goes with the lowest grade, so 6 is the lowest grade, and then all the way up to 10. And there's multiple different combinations of these two numbers. But the biggest thing is that the lower the number, the better, the less likelihood that it's going to spread or spread later on. And the higher it is, the higher the likelihood it's either already spread or will. So now I'll talk about stages of cancer. As I'm sure many of you are very familiar, stage 4 is going to be the highest stage of any kind of cancer. Earlier stages are going to be 1 through 3, and we call those early stage or localized, typically meaning that it's only in the prostate, hasn't spread outside of it. And then there's late stage, or as I said, stage 4, and that's usually when it has spread outside of the prostate, either to the lymph nodes or to the bones. And then stage 4 is further subdivided into A and B, where A is a little bit better than B, and B I always remember for bones. It's already spread into the bones, and then lymph nodes is for A. The prostate, just like any other organ, has lymph nodes that take up fluid nearby. And if prostate cancer grows outside of the prostate, the first place it's going to go is to the lymph nodes, and then after lymph nodes to the bones, and then other lymph nodes outside of that. So to help differentiate between early and late stages, bone scans or PSMA PET scans can help us identify areas outside of the prostate that may have signs of cancer in them, and that helps determine what stage you are. The stage of cancer is really important for determining the treatment and as well as kind of long-term outcomes and treatment options. So first I'll kind of focus on early stage, because that's the most common stage at which we diagnose prostate cancer. Prostate cancer screening has really brought us a long way in the way of diagnosing prostate cancer. In the 40s and 50s, men were only diagnosed in late stages, unfortunately. And now with PSA being able to catch things early when the tumor is small, we've really come a long way. So stage 1 is typically the most common stage that we diagnose. That's the best stage you want to be diagnosed at. And stage 1 is further broken up into very low risk and low risk based on PSA level. So again, you see the Gleason 3+3 equals 6, and again, that's your lowest grade. And then low risk is the same Gleason score, but there's a little bit more pieces that were positive. So if you got a prostate biopsy and just one of them had cancer in it out of 14, that's the best case scenario. Because you have a very, very small piece of cancer in the prostate. And then low risk is maybe 2 or more pieces. And then you have stage 2, it's a little bit more complicated, but you have a Gleason score of 3+3, but you have a little bit higher PSA, 10 to 20. A PSA greater than 10 is a bit on the high side. If you have a first PSA drawn and it's greater than 10, typically we're a little bit more concerned. In the 3 to 5 range, sometimes you can just repeat the draw. And again, stage 2 is further divided into intermediate, favorable, and unfavorable. And that's really just to say that there are, within this group, there are some people, because again, I told you 3+3 is the lowest grade, most likely. Some of the people in the intermediate, favorable, they might not necessarily need treatment. So that's kind of what stage 2 is about. And then stage 3, a little bit higher risk group, further divided into high risk and very high risk. These are typically patients who will need some kind of treatment. So just overall, stage 1, generally you might not need any kind of treatment. Stage 2 is maybe some kind of treatment, but it's still early enough that it would be curative. And then stage 3, a little bit higher risk, this group is probably going to need some kind of treatment. So then we'll talk about the treatment options. So again, early stage, there's a very wide range of, Gleason scores and staging. So Some of them can undergo what's called active surveillance. It's when we're watching the PSA, watching the cancer, we're getting repeat MRIs to see if it changes. And those are some of the patients that we can avoid treatment. And then the other active treatments include surgery or radiation. Surgery involves removing the prostate, as well as the covering around the prostate, and then maybe removing the lymph nodes. As I said, if the prostate cancer is going to spread, the first place it's going to go to is the lymph node. So sometimes we take those out preventatively during surgery, depending on the stage. And some side effects of surgery, because as Dr. Engel said, the prostate is right below the bladder, and it's very close to your sphincter. That's what allows you to control your urine. So removing that, controlling your urine becomes a little bit difficult early on, which typically improves over time. So that's the biggest side effect. And then erectile dysfunction is a common one after surgery. The nerves that go to the penis for erections are going to be affected by any kind of treatment of the prostate. So that's a common side effect. And both of those typically improve over time. Now radiation, and that can be external beam when they deliver the radiation from outside of your body, or you can get your what's called seeds, where they deliver the seeds inside of the prostate, and then the radiation you're exposed to it from within your body. And that can sometimes involve getting hormone therapy depending on the stage. Some side effects of that, again, erectile dysfunction is a very common one. And then because your prostate is close to your rectum, there's going to be some signs of diarrhea because of the proximity to your bottom. And these typically improve. And then also because your prostate's near your bladder, there's going to be some bladder symptoms like burning when you pee and going very often. And that's typically while you're getting the treatment. As for late stage, typically that's only treated with hormone therapy or chemotherapy options, because it's outside of the prostate, and removing the prostate alone is not going to cure essentially. Chemotherapy and hormones do that because they go throughout the body to treat the cancer cells wherever they are. So oftentimes I get asked which treatment is best. So it really depends on a list of things. It depends on your age. You can imagine, a gentleman diagnosed with prostate cancer in their 80s may have different options than someone who's diagnosed in their 50s or 60s. And also depends on other medical problems. If other medical problems are, causing more of an issue to your overall health, sometimes prostate cancer will take a backseat, especially if it's very early. If it's like stage 1, sometimes we'll monitor it while your other medical issues are being managed. And then again, it depends on the risk level. Like I told you before, if it's low risk, most of the times those don't need to be treated because it's so small, it's unlikely to spread, especially if it's Gleason 3+3. It can be monitored. And then really patient preference. It really depends on what you feel best for your body. There are some people who would prefer not to have any kind of externalized radiation applied to their body, and would prefer to have surgery, and then vice versa. And that's going to be a really important conversation to have with your urologic oncologist. So, that, turn it over to Alfonso.
Good morning. My name is Alfonso Taylor, and I am here to share with you my story as part of the patient portal with prostate cancer. In 2019, I attended my fraternity's conference down in Hampton, Virginia, and as part of that, they did have a prostate screening opportunity. I was like one of the last people to go through. And when I did, and they did have a hospital associated with them at that time at the screening, the doctor did a digital rectal exam, and he shared with me what results he could share at that time without information going to a lab and providing other things later on. But one of the things they did find was a rough edge in my prostate. And so therefore he suggested that when I get back home and get the results from the hospital, but also to go and talk to my primary care physician, which I did. Now, my primary care physician is in Charlottesville, and I do have regular visits with him. I have an annual physical. I also have a 6-month checkup for medicines and so forth as well. So eventually, the conversation in May of 2020, I had my first visit with Dr. Christian Green in the urology department at UVA. Obviously, this was also the height of COVID, and the care and the way that you do things were a little different for me then. So when I met Dr. Green, she shared with me, what this process, similar to what the doctors already shared with you, what this looks like and how you handle prostate and your choices. And myself, I had to, wait and sort of gain some information with this. I had to wrap my head around the first thought that you do have cancer, even though I did not feel any different, other than obviously just certain things that they talked about with the frequent urinations and so forth as well. So I did go on an active surveillance for about a year. Again, just to make sure that I understood all my options and I was comfortable. So we got into 2021, still dealing with Dr. Green, who has been my surgeon and urologist for the whole time. She said, well, now you have to make a decision. You have to decide whether or not you wish to continue. 2021, I had the prostate surgery. It was an in and out experience from the standpoint of stay. People will come by and say, well, you look well. I'm going like, this is major surgery. I'm not supposed to look like that, am I? And they say, yeah, you're fine. And so from then on, it's a matter of the recovery. To continue to doing the things that you would want to do as far as your exercise, your diets, and understanding that the side effects that you can have as well. Now, why I opted for the surgery as opposed to the radiation is that with the conversation with radiation, I did not want to have that opportunity to go frequently for treatments. I'd rather have the idea of having this and then start a road of recovery. Now, when this all began in 2019 and definitely in 2020, I knew that one day, based upon my conversations with Dr. Green, that there would have to be a decision. And I needed to make that decision, I thought, later than sooner, but it didn't come to that point. I asked a lot of questions. I asked questions of Dr. Green. She has notes probably of all the questions I asked, and she graciously answered each and every one of them. We were, again, as I said, in the midst of COVID. So my wife could not attend any of the appointments initially with me, but she was gracious enough, Dr. Green, it's allowed her to be on the phone with me and be on speaker, and we could both answer questions and get answers. And eventually, as things did ease as far as restrictions, we were able to attend together. I asked a lot of questions of people that I thought I knew and about what this was happening. I had conversations with my pastor, I had conversations with friends. I had a fraternity brother who was my executive director when I was the state president, and in 2015, or maybe slightly earlier than that, he too had prostate cancer. And I knew that he had a cancer, but I wasn't sure what it was. And he walked me through everything that he did with this process as well. He called me every day and essentially talked about what that looked like, what could happen, what other resources. He shared with me other men that I knew that also had prostate. And he talked about the fact of what they decided to do and the differences of either radiation or surgery. And again, they were good examples of people who had those situations and were fine afterwards. Their lifestyles did not change as far as much as we could all see. But the key thought for me was like, how did this happen? Why did it happen? And as the doctor talked about the different things that go on in your bodies that you cannot see, I was relatively, I thought, healthy. I could afford to lose a little weight, I know that. But for the most part, I don't smoke. I never have smoked. I may have occasional glass of wine, but I wasn't a drinker in that sense. So the risk factors you would think were things that when you do things, when you smoke, when you drink heavily, you could maybe expect some type of issues later on in your health. And none of those were my situations. But again, as explained, it doesn't have to be that. It could be anything that causes it as well. So that was my story. That was the thing that I learned about this whole process was it doesn't hurt one to ask questions, and not everything is necessarily bad. My case, in being in 2019, catch it as it was, and then subsequently in 2020, with the biopsy that I did have, gave me an idea of a treatment plan. I did not have one spot in my prostate. I had several small ones. My PSA levels were different. In retrospect, I look back at my primary care physician's notes, and in 2012, my PSA was at a certain level, maybe less than the 4 that they talk about. And then later on, it had gradually increased up to the 8. Never more than a little bit over the 8. I think it maybe got as high as a 10. But enough to the point that it was at a time that I needed to make that choice and make that decision. For the most part, I feel fine. You know, I still need to lose that little weight. But other than that, my activities are the same. I exercise. I do all the things I try to do. But one of the things that stuck with me in this whole process, as far as talking to people about it, was how it was shared with me, and the courage it took other people to talk about themselves and other brothers to know what was going on. I know men here too who have had prostate and those issues and how they've handled it as well. And I too obviously believe in medicine in the sense that you do have the opportunity to have good care with a primary care physician and getting the regular checkups. And then sometimes even doing all of those things will not prevent something coming on you later on. One of the things I will say as I shortly end this is that I used to listen to a radio show called the Tom Joyner Morning Show. It's a syndicated show. We no longer get it in the area in which we are. But one of the things he did on his show was in every September, as part of Take a Loved One to the Doctor, the 3rd week of September, they encourage someone to take a loved one who would probably never go to the doctor, refuses to go to the doctor, to make an appointment and take them, you know, be with them and go and have them checked up and see what was going on in their lives. And I think that is something that stayed with me, is that if you truly care for yourself, if you truly care for your family, your friends, if you say that you love yourself, your spouses, your significant others, you want to do everything that you possibly can so that you are not the burden to them to take care of you at some point in time later in your life. Obviously, that's more so for men than for women, but it does go for everyone. Thank you.
Wow, thank you, Mr. Taylor. That's a very powerful story, and thank you to Dr. Eagle and Dr. Billabor for sharing a lot of knowledge around prostate cancer. And so I know we've thrown a lot at you, and soon we're going to open up to some questions, but I think to make it interactive, I'm just going to say some things that I think I heard and have you guys, since you're in church, you can do the recite back kind of piece and get you active. Do you guys remember what PSA stands for? What's the P? Prostate. The S? Specific. And the A? Antigen. Yep, so prostate specific antigen. And how do we measure that test?
By your blood?
By your blood, that's right. So you get a blood draw to measure it, that's right. And then what we didn't say so much is sometimes there's a value. If it's above a certain number, we get worried. Does anyone know what that number is? If it's greater than what number will your doctor probably recommend a biopsy?
Mine was 1200. Mine got to 1245.
It got to 1245. Okay, well, we're going to talk about 1245. So if it's above, I heard over on this side, number 4. So if it's above 4, then that's when you want to see, your primary is going to probably refer you to Dr. Billabor to get a biopsy. The size of the prostate is usually about, people say, the size of a walnut. And if you kind of rub your nose, it usually feels about the consistency of your nose. And so what Mr. Taylor shared is that when they did the rectal exam, is that they felt some roughness. And sometimes we'll use that term, a nodule. So if you hear the term nodule or roughness, or in duration, those are abnormal findings. And so you need both of those things, because sometimes the PSA won't be above 4, but if the exam is abnormal, then you still should probably get referred to Dr. Billabor to talk about a biopsy. And then, what's the most common cancer in men other than skin cancer? Prostate, that's right. Okay, you guys are getting 100%. And then what are some other important diseases, reasons to have a good primary care doctor like Dr. Ingalls, so you can get screened for blood pressure, diabetes, sugar diabetes, kidney disease. All right, you guys are knocking out of the park. That's right. And then when you go to the doctor, just like if you went to Lowe's or you went to the grocery store, if you got a list, sometimes it's going to help you have a better experience. So have a list, like what do you want to get out of this visit? Because sometimes as doctors, we get busy and we may not be thinking about everything. And so when you have a list and you're like, well, what about my prostate this year? And that may help your doctor to do the best job for you. I think what Mr. Taylor shared, which was super, super powerful, was events like this and how his fraternity had an event where they did a screening, and then that was the kind of the aha moment that got him detected early. And Dr. Billabor shared, early is usually always better than late, right? So early, we catch it early, we are able to treat it early, and this is where outcomes or success of the treatment are equal for African American black men versus non-African American or white men. A lot of those differences are due to us not getting detected early and then not getting treated early. And so we can fix that by doing what Mr. Taylor did. Sometimes we can't, and I want to, because I heard 12:45, so we got to come back to that, or the doctors do at some point. But you guys are doing great. So with that, why don't we kind of just open it to any questions that anybody might have, and then we'll do our best to answer them. Yes, sir.
The doctor mentioned that at age 45, you should start checking. Is there an age where you're not, is there an older age where you're not likely to develop?
Yeah, great question. So usually, especially if you're at higher risk, I would say 45 is right. For some people, no family history, not African American, then maybe a little bit later is okay. Usually we say age 50 to 75. After 75, again, it's a conversation still, but after that time period, regular screening's probably not as important, or, we probably won't do that as much if you don't have symptoms. So usually 75. But again, that's where you and I in the doctor's office would have that conversation to see what are your other health issues, how do you feel, we'll ask some questions, and then, we can kind of make sure that that's the right age for you, if that makes sense.
And then also, I totally agree with Dr. Engel, but I also want to preface that there are some national guidelines that also recommend for people who are a little bit higher risk, family history, African American, and certain genetic predispositions, and tested a little bit earlier at the age of 40. So 45 to 75 is about average risk people. But if you have 3 brothers or a dad who have prostate cancer, you probably want to be seen earlier for your first PSA.
So on that note, like I expressed my dad's like 77 now. Well, a couple of years ago, so around 75, the doctors told him that if he didn't do anything, but his numbers creeped up, but if he didn't do anything, it would probably be 20 years, it would be almost 90 by the time this would take effect. So to that point, but he went ahead and he wanted to get it taken care of. And he had the seeds done, I believe, the seed treatment down in North Carolina, and that I mean, to the ladies here, it's a sensitive thing for men. It really is. You're talking about our manhood in our head, right? But talk to your family about what's going on with you, because when my dad got checked, I'm 54. But I've been being checked since I was 40, not because it's a long history, it was just something I didn't want to do. I just wanted to know. I'm those guys. I just get my doctor fixed. Because I'll sit there and I'm asking them everything. So do that. I mean, talk to your family, tell your kids, especially your sons, your grandsons. This is something that's real, and it affected me majorly because we did not know. My uncle passed. We had no idea in the family that he was that sick. So we get a phone call, he's gone. And he didn't tell anybody. He was like a big brother to me. So it's like I lost my brother. And I didn't even know he was sick. So, talk to your family about that. Because it does affect not just you and your children, but even your nieces and nephews and stuff. Get checked, man. God will be out. God wants you to get checked. That's what we're doing.
And you make a really good point. Over the age of 75, it's very reasonable to get your prostate cancer treated or to be checked for it if you're in really good health. If you have 15, 20 years ahead of you, it's very reasonable to have that undergone, especially if you have really no medical problems and you're otherwise very healthy.
One question that I would like to ask is why specifically in this specific area is the incidence of prostate cancer, why does that seem to be higher, especially, Madison, Rappahannock, Orange, around in this area? I understand that the incidence of prostate cancer is a little higher.
Well, I'll take part of that. I'll first say, I don't know if we know, right? There's gonna be some of these things, these are awesome questions, but we don't always have the perfect answers. With that said, some of it probably comes back to this question about screening and having enough doctors in your community, maybe education. I'm learning something today too, right? When I go back and see patients starting Monday morning, I'm gonna be a little more sensitive to maybe a few of my patients who come in who are a little bit younger, and I'm probably gonna ask a few more questions about their family history than I would have a week ago. And so this is good for all of us. But with that said, I think that's kind of the goal, is to give you all this information, make sure that you have a place where you can be screened, and then hopefully we catch those cases earlier, and then we can affect those numbers.
I would just echo what Dr. Engel says. I think prostate cancer development is a very complex process. There's no one thing that can be identified to say this is why everyone in this area is developing it. I think a lot of the problems or things that we look for is there enough access to specialists or primary care physicians that can help people who have been diagnosed with. I think those are the things that we try our best to focus on, things we can control. There's a lot of things outside of our understanding scientifically that can explain some of these things. That's a good question.
I have a question for Brother Taylor.
Yes, sir.
I take it you're about a year past surgery?
In October, it'll be a year.
Okay. Are you fully recovered now?
I think I still do regular tests. Every 6 months, I go for PSA tests, and Dr. Green always tells me my levels are good. It's like a negative 0.01, which is a good thing after surgery. I don't think full recovery is a word that comes, because I think there's still things that you're saying from the bladder control that you still work on and will work on for a while. Even my fraternity brother that I talked about, who happily posts that he's been cancer-free for 10 years, telling me he still has those urinary situations. So that's just part of it. But for the most part, the worst I felt was quite honestly right after the surgery, having the 2 or 3 weeks to start the recovery process. Beyond that, then yes, things were better, and definitely exercising and One of my biggest problems of watching a good diet is one of the things that you have to do as well.
One other question to follow up there. You said you still have a PSA exam. How does that play into the surgery having been performed?
For me, I think it's, and the doctors may be better able to answer that because I'm not sure what that level could have been after the radiation. One of the things that prompted me for the surgery as opposed to radiation was the fact that I was, and shared again with Dr. Green, was if you had the radiation and opted for the radiation first, and if it reoccurred, cancer reoccurred, you might not be able to have the surgery. And I didn't want to have that chance. And again, talking to people who've had both and hearing others who have had a reoccurrence, I wanted to have the opportunity to have the best results possible. The PSA test that we now do is, again, just to monitor and ensure that things are well. And as I understand it, I will be doing that every 6 months for about a year, and then maybe after 2 years, every year. And hopefully, again, I start having those historical time periods that it's only just once a year.
So I can also comment on that. So after a prostate procedure for cancer, after a prostatectomy, there's no more prostate, there's no more prostate tissue, there's no more prostate cells. So your PSA, which is produced by those cells, is essentially zero. And when you said less than 0.01, that's because the tests that we have don't measure zero. So they say it's less than this number. So that's the blood test that he's referring to. And that helps us determine if the prostate cancer comes back. Because then your PSA starts to increase, right? It should be zero if there's nothing there. If you have radiation, the prostate's still there, and some of the normal prostate cells do produce PSA. So it's not going to be zero, but it'll be kind of like almost zero. But also you would still continue to have to get a PSA draw to see if that level increases. If there are leftover cells within the prostate that was treated, that may start to grow back. That's kind of the nice thing about surgery, is that afterward you have kind of a zero, you're at ground zero, and that's easiest to kind of monitor later on. Whereas after radiation, it's kind of zero and it can fluctuate as well. Whereas after surgery, typically it doesn't.
What's the normal PSA for, I mean, just healthy men, what's the?
So that's a good question. It varies. It varies very widely. I have had some patients who, their prostate is normal size and their PSA is 12, all the time. It's been 12 for 10 years and they've had 5 biopsies, So it really depends on the person. That's why it's important to know what yours is, in your 40s, because then you can kind of track it. There's no real one size fits all. There used to be back in maybe the 70s, 80s. We used to think 4 was, above 4 was abnormal, below 4 was normal. And we found that it's really a wide range, and it's really person specific. Your number might be 7, and it's always been 7. Or yours might be 3, it really depends. But the thing we worry the most on is velocity. If it's 7, then 8, 10, and it continues to rise, that's more worrisome. But your prostate cells, they make a certain amount at any given day, and that usually doesn't change over a couple of months to a year.
And that's the power of Mr. Taylor's story, is that he knew it, right, because he had been checking it. And so then it was 4, and it was a good number, and some boom. Then it went up to that 8 range, and so you're like, aha, that's the difference. And so if you're getting one every, year, then you have multiple numbers, and then if something's different. If you just show up out of the blue, and then you get it, and then you lost and don't see your primary care, and then come back again, it's hard to put all the pieces together. And one other important point from your question, sir, is that when we're screening with prostate cancer, the PSA, the elevation can be from many things. Like Dr. Engel said, it could be cancer, it could be enlargement, it could be infection. So it's not as specific as the name says, but after you've been treated and we know it's cancer, it's a very good test. So when you get your surgery done, it should be, like Dr. Billibor said, zero or undetectable. So it is like better than anything, because now if it goes up, we know it's from the cancer because the prostate's been removed. So before, when you're doing the diagnosis or evaluation, not all that specific. After you've had treatment, it's like gold, you know, it is really helpful. So if someone's like, oh, nope, after you've had surgery, you need to check it. It's very, very, very reliable.
But I will say this too, because I just checked mine. So, UVA has a MyChart program, app, and it is excellent, because that's how I check mine. I keep all my stuff. I said, let me go to my blood test real quick and see what it was last time. So, but that's a good way, the technology of having that app or knowing that app or being able to look at your chart almost real time. So that I commend you for having that, because that's a lifesaver a lot of times, because it has a chart on there to say, look, you're creeping up, you know. So that's a good way to kind of monitor it as well. Yeah, I'm good.
That's good.
That's a great point.
I'm so
In
happy
that,
right now.
I mean, I love my chart also.
Yeah.
Because in the part of the goal of it is that we communicate better, right? That you have the information. Like Dr. Downs was saying, sometimes we get busy, or, you know, I see what it is and it looks fine today, but maybe I didn't go back and look at the graph and realize that it is creeping up. And so, you know, you asking that question would be helpful, right? Or it would draw our attention to it. And maybe it's, you know, maybe we decide it's not enough that we're worried or whatever, but maybe it's something we decide you do need to have checked out. And so I do think that that's a really good tool. And you can share it with your other doctors. So if you were to be, I don't know, if you moved, you have that information still. And so that's kind of the goal, is to give you that power.
So what are some, what question I have is, what are some preventive things that you can do? I've heard eating more broccoli, asparagus, I've heard all kinds of stuff. What are some of the preventive things that, you know, nutrition-wise, that men can do, that if you are in a good range right now, that you can try to, I know things take its course, right? But what are some of the things that we could do?
Maybe we'll take this one
Yeah,
together. I'll
absolutely.
start with a couple.
Okay, well,
So-
I think the first one that I'm very interested in is exercise. You know, the American Heart Association has great recommendations on physical activity. It's 150 minutes a week, which is about 30 minutes every day, or about I guess if you're Monday through Friday. So that's really helpful. And there are some really exciting studies that are showing that people who exercise more before getting diagnosed with cancer, if they do get diagnosed afterward, they're more likely to live longer than people who don't. And those are people who are well below the AHA recommendation of 150 minutes a week of moderate exercise. So exercise, I think, is a really important one. Regular exercise daily, if not at least 30 minutes for 5 days a week.
I think the other piece of that is there's no one thing that's magic. The way I kind of think of this is, you know, each one of these things is a chink in the armor, right? So if you're wearing an armor suit and you have a family history, well, that's a chink in the armor, right? Can't do anything about that one, but it's a chink. You know, if I'm exercising, maybe that gives me a little extra protection, but, you know, maybe my diet's not great. So is that a chink or a half of a chink? Maybe, right? So the goal is to really control the things that you can, at least to the best of your ability, right? We're not perfect. You're not going to eat right every day all the time. We're people, we live, we got to enjoy things, right? But in moderation. We do think that things that help control free radicals, which is kind of, I don't know, to me a big kind of loose term out there, but, you know, so vegetables in particular or other healthy whole foods tend to be more protective for us than some other things. Versus, again, like we said, processed meats or some of those sorts of things. there's a lot of talk about supplements, and I don't know, I'm gonna let you answer that because I think you have some better information than what I have, but.
Yeah, so, supplements are a huge one that I get asked about a lot, things like saw palmetto and, beta prostate, those kind of things. And as Dr. Engel said, there's really no one specific thing. These supplements have been studied widely, and you could find any study you want, and one will say, yes, this definitely prevents you from having prostate cancer, and then you can find another one that says it definitely doesn't. So the literature on supplements as a therapy for prevention is really mixed, and it really just kind of depends on what study you look at. Overall, I think the only thing within the literature, within kind of the overall gestalt of literature on supplements is that, having a healthy diet probably really trumps all of those things. Selenium is another important supplement that they used to think really helped prevent prostate cancer, and that was kind of disproved in certain studies as well. So I think a healthy diet with low fat, low processed meats, high in vegetables and fruits really kind of outweighs any specific supplement that you could take daily. That being said, I do have some patients that, swear by saw palmetto and stuff like that, and that's okay, in conjunction with a regular diet of fruits and vegetables is fine.
I know we've talked today about prostate cancer, but we were talking about an enlarged prostate, BPH, which is benign. And one of the things I found is that men that suffer from an enlarged prostate, benign prostate, by taking the supplements and saw palmetto, they delay going to see that primary care and they don't get all the symptoms. What's the risk of doing that, of trying to self-treat versus getting into the primary care physician?
Yeah, I can start with that, and then if you follow up, that's fine. So I would say in general, I don't know that we have a problem with saw palmetto. We haven't seen necessarily bad side effects or concerns with it. So if it helps, I think that's fine. I would say that although prostate cancer doesn't usually have symptoms, I would just make sure that you're talking to your doctor, or at least have your PSA, so that we're not missing an enlarged prostate that's coming from something that's a problem versus the benign, right? But with that said, if that works for you and you don't have to take a medicine, I'm fine with that, right? I don't want you to be on any more medicines than what you need. Now there are medicines that can help, but, so if you find that you just can't sleep, or you're up, can't sit through church or whatever, then, that can be helpful. But yeah, I would say in general, we're not too concerned about that as long as the PSA is normal.
I was just laughing. I was a pharmacist. I want you on as much medicine as
We keep you busy sometimes, right?
If you have BPH at a younger age, say in your 30s or 40s, is that a strong indication that you will have the prostate cancer at an older age?
That's a really good question. So there are some interesting studies that show that BPH may be protective of developing prostate cancer. Prostate cancer is on the peripheral zone, or the prostate that's closest to the rectum, whereas BPH develops close to the urethra. And they think that pathophysiologically, the prostate cells near the urethra that get bigger kind of push the prostate cancer out, or squeeze it to where it's so small that it can't develop. So typically what I've seen is men who have BPH at a younger age usually never diagnosed with prostate cancer, and then kind of having a big prostate may be protective in a way of having a prostate cancer later.
Yes, my concern is, I was diagnosed 18 years ago, and I had prostate removal 16 years ago. But during the progression, I noticed my bladder control got worse. If I raise my hands above my head several times during the course of my work day, or prostate removal, because I did that, like, Alfonso's stories. My story was just about the same as yours, but it was just 18 years ago. I'm 80 now.
Oh,
So,
wow,
you know,
you look good.
I feel great.
Yeah, you do. He does look young.
Thank you, but,
He does.
but that was my major concern. Is that what you have to look forward to after prostate removal?
What I would say is congratulations, sir. It's really wonderful to hear you're still doing so well. That's really wonderful. And it actually is. Continence or your ability to control your urine is based on three things: your bladder neck, your prostate, and then your sphincter. After prostate surgery, your bladder neck and your sphincter, undergo some changes, and then your prostate's gone. So you really don't have as much. You kind of are on two things that are going to help you get your control. And over time, as you get older, those do get a little bit weaker with time. So what you've described is very normal in the gradual kind of progression of control.
And while I would say it's normal, it doesn't mean that it's fun, right? I mean, it's one of those things that, you're alive and you're doing well, but it doesn't mean that, sometimes it can be an issue within relationships and different things. And most families, couples kind of weather through that. And some of it can happen just naturally with age as well. But yeah, it can be a challenge and that's hard. One of the things we do have now is there are more options for, various kinds of incontinence sorts of guards or pads or those sorts of things, and the materials have gotten better, so some of that's good, but it's still difficult.
Yes, and she's exactly right. There's a lot of options for it, actually. Both procedural operations that you can undergo to help with that, and then other parts as well. So I would strongly suggest you talk to your doctor about other options or referring you to someone who can kind of help you manage that, because there are a lot of things now.
Thank you.
I just had a point. The difference of having that surgery 18 years ago versus his 2 years ago, the technology and the treatments have changed in that period of time. Considerably, okay.
But that was smart on your part, that 18 years ago, you did something about it, and a lot of men just don't, they just don't want to bother with it, so you'd be commended, sir, to do that. That's a good story.
Again, like I said earlier, most people don't have symptoms, and I see that a lot, but I don't have symptoms, I don't want to do anything right now, but, in your early stage, you have a lot of options, but over time, those options kind of diminish, when it gets into more later stages,
So what's the percentage of survivability at early detection? And then I have a follow-on question to that. What are some other things that men can do? Let's just tackle the big 800-pound gorilla in the room. What are some other things men can do? I think we know some of them for the ED problem. If you're a young man or something like that.
So, prostate cancer, again, is very slow growing. So most people who are early stage who are treated, they have 10, 15 years ahead of them. Any study that you look at that looks at prostate cancer's, mortality, they have to be a 20-year study, because we know that the bulk of people are going to be alive at 10 to 20 to 15 years. So it's very, very successful. And even some people who are never treated are still, again, it's going to be grows for a very long period of time, and maybe 10 years before you have some kind of problems. And then to answer your other question about erectile dysfunction, there are a lot of different options for it, both medically and surgical options. The first thing that probably primary care doctor is going to probably put you on is a phosphodiesterase inhibitor, which are the pills, or the little blue pill kind of thing. And then we can titrate that all the way up to surgical options. So there are a lot of options for you. Unfortunately, ED is very taboo. A lot of people don't want to talk about it. But our hope is that things like this will kind of help improve people's willingness to approach their physician about it and get treatments and options.
And for ED, I would also recommend prevention. So the big thing there is smoking. So if you can stop smoking, that really helps. We didn't talk about smoking with prostate cancer. Bill had asked me a little bit about that before. And smoking is, again, one of those chinks in the armor, right? So if you smoke, your risk of cancer is going to be a little bit higher, but it's not specific for prostate cancer. Smoking tends to be worse for like bladder cancer and lung cancer and others, but not so much for prostate. Other things that can help prevent ED, frankly, my job as a primary care doctor is real easy because the prevention of almost everything is all the same stuff. Don't smoke, exercise, watch your diet. If you have diabetes, control your diabetes, control your high blood pressure. One of the urologists, I was at a talk, this has been probably 10 years ago, Dr. Costabile was giving a talk to primary care, and one of the other things we'll tell you about ED is that, especially if you're younger, like 40s, 50s, we sometimes think of that as the first symptom of heart disease because it's based on circulation. And so sometimes we want to make sure, you might come in and talk to me about erectile dysfunction, and I might ask, are you having chest pain or shortness of breath? And you're going to think I'm crazy. But it's partly because we're just trying to monitor, all of your circulation as well. So really focusing on prevention is good too.
I wanted to see if I could ask Mr. Taylor just to maybe share his journey in terms of decision making. It's not too uncommon for a patient to, tell us to not tell their loved ones. So they may say, oh, I've got prostate cancer, but I really don't want my daughter to know who's away at college, or I'm not so sure, I'm ready to tell my partner or my wife because can you just share how you walk that? And
Yeah, that was a little hard at first too, particularly from my demeanor. I'm a relatively private person. I don't talk a whole lot for the most part. When I do start talking, sometimes I can't stop. But for the most part, it became important, I guess, once I learned what it was and started talking to other, particularly my fraternity brother, really. He was my resource. So as being that resource, it gave me a calmness as far as this is not just something that happens to just, everybody it can happen to anyone. It's not a problem. And then when I started talking to my urologist, and Dr. Green was so reassuring and talking about what the process is and answering all my questions, that it was, I could not talk about it to other people who I thought may be interested in knowing. And to talk to a family and sharing with everybody else what was going on, sending texts, telling them what was happening, trying to explain the things that were medically, terminology-wise, what was happening as well. And but the most part, alleviating myself and others of the fear. One of the little things I wrote down as far as my notes is when I was in college, the first thing I heard about cancer was like in 1973 out of a book by an author says, First You Cry. And it was a lady talking about breast cancer. And, we always think of breast cancer being very predominant with women, but men have breast cancer too. But coming forward 40 years from now from college, is that learning that there's cancer can be of all shapes and sizes. I never thought I would have prostate cancer. That's just something I didn't think would happen. I didn't smoke, so I didn't think I would have lung cancer either. I felt pretty sure with that, unless I was working in some type of chemically based area. But it's the things that you don't know are the things that you perhaps will want to know. And once you know it, it's just like, why not share it? It's one of the things I think we particularly as Afro-American people, we have a hard time sharing stories. We learn about our histories. We talk about our family histories. We know that somebody died of heart disease, but we don't know exactly why it was the heart that killed them or something else. We know that we have diabetes in that family. We don't know whether the land that we lived on, the diets that we had, the medical treatment that we did not have over the years. I'm 66 years old, and I can remember people living back in the country, as we call it, who lived longer periods of time, had no illness whatsoever. They worked hard, they ate everything they wanted to eat, but yet as we progressed later on, certain things happened and we had no real reason why, because we never had the medical attention that we needed to have to do that.
No, that's so important to like share, and I think it's almost like as you get to a certain age, it's now our responsibility to sit down with our sons and daughters and say, this is what I've got, because this may be coming your way and also part of the family history. So and it's interesting when you say that, because, from our, how our experience has been, the American experience as black folks in this country, our oral history was really how we communicate with each other. So we have a rich tradition with that, but yet in terms of our health history, we don't continue to do that. So let this be an encouragement. And I'll just share one part just for the maybe the women of the men who might get diagnosed with something, and what I share experience I saw with a couple I took care of, and the wife wanted to know everything about it and needed the support, and the male was more withdrawn, and he's like, just tell me when to show up, tell me what I need to do, that's it. But didn't really want to have that communication, which I can imagine was just eating away at the partners, like, let's talk, and so sometimes as physicians, we have to manage both individuals, and they're not, we're like the patient, remember the patient, but sometimes you gotta remember who's with the patient. And then, and so what I found that sometimes helping them know where to get the information, or their support groups, where sometimes the wife would be a part of the support group and hear and learn everything, and that was actually stress relieving. And then they would give that and share bits of that information with the male at this time, depending on. So all of our relationships are different. So I'm just saying, however you guys make decisions, continue to do that, and to know that as a male, you're closing in might be harmful to your partner, and so don't make them handle this journey the same way you are. Allow them to be that person they've been the whole way through, as they're going through it, because they're hurting too, right? They're hurting too. It's not just you being diagnosed with something.
Doctor, that Charles reminded of my own family. For younger men that are getting tested, my daughter she had a seizure. She graduated from college. Turns out she had blood clots in her head. We didn't know this, don't know how they got there. Where my mother suffered from strokes due to blood clots. It turns out that my daughter, when she found out from the doctors what were causing her blood clots, it mirrored what my mother had. So when my mother told us, my dad told us what it was some protein, something that was causing her to clot irregularly. It turns out that my daughter, who's her granddaughter, may have the same thing. Now we don't have it, but now that's something in our family that we're passing on. And I told my other daughters, you may want to get checked. So to all the young men in the room, if you go get checked, you may find out something that you can tell your dad or your granddad and say, hey, granddad, I'm finding out I got this. You might want to go get checked out to see if it affects you too. So it works. This is a two-way street.
Yeah, and for you to share that, like I'm thinking, you guys think of Factor 5 lighting or something?
Right, or
Yeah.
C or S,
Yeah, so we're like, oh yeah, this, second year of med school, but there's that component of like, if we don't ask about, what about, your grandma, at that time, we won't pick it up. And so that's the power of like you guys saying that, and how that may have like changed the dynamics of your daughter's life for good. Yeah, and it's not all that complex, but it's just that part of you guys talk, and then you shared it, and then we're all like, oh yeah, sure, whatever, it's A, it's B, C, and we're like, just take this, life's done, it's over, it's good. But it's that part of that discovery part. So, proud of you guys, and just, and for doing that. So thank you for sharing that with them.
My husband thinks the journey sounds really easy, but our journey, to me, wasn't easy, because I felt like I wanted to know everything that you knew, what So that was really important when Dr. Green would allow him to have a phone conversation. I could ask questions and hear what he didn't hear. I felt like I heard part of the conversation that he didn't pick up on. So to me, that was really important. Communication, opening the door, because I had dealt with it with my father having prostate cancer before, so I had a lot of questions that I couldn't ask when it was my father's turn, that I needed to ask now because I didn't want him to be in my father's shoes. So I felt like communication, us talking about it, I was more anxious for him to have the surgery than he was, I felt like when she told me that if you have the surgery, you have the possibility of going back if something comes up to have the radiation. So I didn't want to do the radiation first because you couldn't do the surgery afterwards. So I wanted to make sure that he understood that part of it because it was just everything to me in our life to me was on slow keel. It's okay. I'm gonna do this. I'm gonna do that. No, we need to pick up the pace. I need to see this in action. I need to see this through. Was my anxiousness as a wife, as a partner, as the person receiving the information on the other end of it. Because if something ever happened to you, I got your bad kids. So you need to be here. You need to be here. It was just something that I felt like we needed to be in together. It wasn't something that you can go through this and it's gonna be fine. You just tell me what you want me to do. I needed to feel like I had a part in it. I needed to feel like I needed to participate in his decision making and us talking it through and finding out what we needed to do. So to me, the communication needs to be there for everybody. I have my brother here. The communication of you knowing that our Father had this, you need to be checked. I don't want to lose any of my loved ones to something that we can do to help ourselves. So that was my part of it. That was the journey, the road that I felt like I was on, or is on, with my husband with this. For the record, I'm not the best.
Thank you so much for sharing that. It's so powerful, and it just enriches the journey, right? It's more than one person on the trip,
Yeah.
right? And so yeah. So thank you, thank you.
I have a question.
Yes, ma'am.
I have a uncle he's 82, 83 years old. He found out that he has prostate cancer last December. He fell and broke his hip during Christmas time, having his son cut Christmas nights. He's more concerned about getting his health back, his hip healed, more than going for treatments. Now, I heard the other gentleman, he was out asking about how safe you are when you're 80 years old and you still contract having this problem. But he's in his 80s now, and he's more concerned getting his hip back mended than going through his treatments. So what if you would share about what needs to be done, one thing off, because you're worried about walking and getting that part of it back before you go through what treatments you might need down the road. Yeah, just can't stop. What's that? Progressing faster.
No, you make a really wonderful point. Prostate cancer is very slow growing, and as you get older, the likelihood of it spreading and having enough time to spread to cause you symptoms is usually shortened as you get older, because you probably need 10, 15 years before it causes real issues. So really, prostate cancer in the setting that you described, it would take a backseat, certainly. Healing from a hip fracture is going to be a top priority. Your overall health has to really be set before you undergo any kind of prostate cancer treatments. So I would certainly agree with that.
Before I don't know, did you have no, sir? Okay. I know you shared the value of 1245. Were there any questions you wanted, sir, to ask or us to talk about with your PSA?
Well, mine was 1245, but then they give you a shot, and that knocked it down to 7 something. And then it started going on down all the time. I had to go through chemo, I took 6 treatments of chemo. And it would go down every time she checked it, going down all the time.
You guys want to talk about that?
If you're okay with sharing, do you remember the first time you had your PSA? Was that the first value you ever had? The 1245?
Yeah. And then the first treatment, knocked it down to 7, went down to 700. And it just kept on going down all the time. Now it's down to go 6 last doctor appointment. I got one the 27th of July, but the last one was down to 6.
Prior to that, did you have like a primary care doctor that you see regularly before all that?
Well, I go to Dr. Martha Jefferson, the lady doctor. Then I got a doctor in here, that's a family doctor. But she checks it every time I come in, and she take off, and then she calls me back every week.
Yeah. So, I mean, I think, that's an amazing story, and I'm glad it's going in the right direction now. I think, maybe just the take-home point is, this is why it's really important to have a regular doctor.
Mm-hmm.
And I'll tell you the other thing, and I think Dr. Downs said it a bit earlier, sometimes we get sidetracked by something else. Maybe you've come in and we're talking about blood pressure every time, or maybe back pain or something, and it's partly why we try to have a physical or something, or at least in our mind, to have a time to really talk about your whole health. Because if we're talking about various things every time, sometimes we'll forget that we need to do these regular screenings. Our computer system now tries to remind us to do these things. But again, it's why I don't get offended if people bring a list. Now, if you've got 20 questions, I might have to do the list over a couple visits. But in general, I'm okay. I want you to be aware of what's going on with you. And the only way that I can have all the pieces to the puzzle is if you share that with me. And so I'm really honored when people feel comfortable sharing that. And then, again, it's a partnership. We're going to sit down. We've got to think about what's on that list. And then we can make sure that we don't forget or lose track of, oh yeah, we got to make sure we check that prostate, or how long has it been? Let's make sure that we're keeping up with your colonoscopies and, whatever else. So that we can do the best we can with your health overall. But again, I really think it's a partnership, and I think the really important thing is to have somebody that you feel comfortable sharing that information with, and that you can feel like, is paying attention to that.
I have a question or just a comment. In my family, it's a lot of male. My son, I got sons and nephews and all, and I sit around, I listen to them talk, and they talk about they're in their 40s, late 30s and 40s, so they're very sexually active. So they're on blood pressure medicine, which is something having family. So they're on a lot of blood pressure medicine. So they don't want to take the blood pressure medicine because it's going to affect them. So if they're doing that, not taking the medicine for that, then they won't get checked for that prostate because they don't want that to happen to them, and that they may become ED. So they're young.
Yes.
So how do you kind of like talk to them and really try to persuade them into?
That's backwards. Tell them if they take their blood pressure medicine, they definitely don't have a problem. I mean, let's just be real about it. I mean, that's just a backwards way of thinking. That you're thinking if I take blood pressure medication, then I'm gonna have a problem. No, you have a problem if you don't take it.
Well, that is true. I mean, yes, that is what I have said to them about that. But they still, that's not important. Not right now, that's not important.
Well, sometimes it is hard when people are young to have them understand. With that said, there are medicines sometimes that do affect erectile function. Blood pressure medicines sometimes are one of those. And so I would encourage them to tell their doctor, like, okay, you want me to take a medicine for my blood pressure, this one's giving me a problem. There's enough blood pressure medicines, we should be able to find one that works for them, but without the side effects. And I hear our pharmacists, yeah. So I'm on the right path. But no, I think those are important, right? Because those are, quality of life sorts of issues, right? But if we don't help them with that now, then it's a problem later too. So, we don't want it to be a trade-off.
I just want to let y'all know the power of this session that we're having. Over in Africa, Kenya, they're watching this.
Oh my
And Pastor John Shege wrote back over Facebook. He said cancer is a big issue here in Africa, especially to men since they keep quiet. So it's not just an American problem, it's a global problem. And he said the second leading cancer over in Africa is prostate cancer.
Wow.
So, he then says he hopes that one day we can come to this country and do a clinic. But he's watching right now, so he thanks us for having this so that they can just let y'all know that you're worldwide right now.
I guess we want to be mindful of everyone's time, and first I just want to say some more thank yous, and then I think Pastor, you should close us out. But first and foremost, thank you for investing in yourself, as well as the folks that are going to benefit hopefully from some information you got today. So hopefully you feel like you left with a little something, that you didn't come with. And it wasn't the bagel or the good coffee or the fruit or stuff like that, but hopefully a little bit more information about prostate health and men's health, and that it's something you can hold on to. We will have contact information about how to reach us. Again, a big push that if you don't have a primary care, get a primary care, that access to someone who will be entrusted with your health is life-saving. And sometimes it's those small things we do that add up over time that make a big difference. We definitely want to make sure we give you a shout out and thank you for sharing your journey and letting us learn through your great decisions and your family's decisions. And want to thank the doctors here who shared their wealth of knowledge and what they do and how much they fight for their patients every day. And just Kim and everyone who's been a part of this. And so, Pastor, if you'd like to kind of close us out. And, oh, yes, sir.
First of all, let's give our panelists an order of thank each and every one of you for coming today. Like I said earlier, we have to educate, advocate, and participate. And so hopefully today you've been educated. You left here today with some knowledge. And now for those that are not here, we want you to go out and advocate to them and tell them, the ones that are not here, your family members and all, and we want you to do that. But also we want you to thank you today for participating. So all of you got a little ticket when you came in here. And I'm gonna ask my wife if she'll get on this one. Could you run back in and bring those 2 items out here for me, please? We've got a couple prizes here, and before we thank, I want to thank Kim. I mean, she hasn't said anything, but UVA Health and Kim are behind this, and the old time working unseen. She's been doing a lot of unseen work, but without her and UVA, this wouldn't be possible. And so, a couple of things we gave you today. We want to give you, we've given you tools, but and I wanted to limit this to the men here because I didn't think women would want tools, but I was informed that So I don't know who has the cup with the numbers in it, my wife over there, but, bring it and set it up here, we got a couple of prizes. Each one of you today got a card that gives you a free complimentary visit to PAL Wellness. And we talked about, healthy exercising and all like that, but we have a couple of prizes here. So the first prize, we're gonna give everybody an equal opportunity to win this, and we're gonna give you a tool box and the tools to get some other jobs done at your house. And so I don't know who you're gonna get to draw it ever. Get Pastor me in
Pastor
there.
should, yeah.
But you do it.
Or can't, yeah.
Is it?
Let Kim.
Ask go through and see if you get in.
Okay, the winning ticket is 858094.
Off by one.
094.
And then also we have 3 1-month
Wow, he got
certificates
Both
for
of them.
the
He got
PAL
both of
Wellness Center. Everybody gets to go visit them one time, but 3 people here today are gonna get a whole month to go to the PAL Wellness Center. And, you know, hopefully you'll come out there with a little less weight and a healthier, and those are in that brown envelope there, so there's 3 of them in there. Oh, the big ones. We're working there, that's about it. Yeah, 1-month membership to the PAL Wellness Center.
Okay. First winner is 858076. Congratulations. And the second winner is 858089. Final winner is 858085. Oh, correct? 085.
Stay there.
Gotta be present, we're gonna draw it in. Okay, how about 858080?
That's usually 80.
080. Winner right here, congratulations.
Again, thank each and every one of you. And Kim, if you just wanna have some comments before Pastor Williams comes and closes this out?
Really just want to thank you all for joining us, taking time to be here today. It was truly a partnership. This really came from Eugene, who brought this forward, and it's just been a pleasure and an honor to work together in partnership to bring this together. Also want to recognize Green Care Clinic that is here that has some information available. So for anyone that wants to pass on that information, we welcome you to that. We do have a sign-up sheet. We are looking to plan a screening events and additional health programming. So if you have interest in that, we welcome you to leave your name and your email information or a telephone number so that we can contact you in the future about future programs. So, thank you.
Okay, again, we want to say thank you to each and every one that came out today. I think it was very informative. all the participants. We just want to thank all of you who took time out of your busy schedules to come out on today. And as Eugene has said, we hope that you will go out and share the information that you have received on today. We're going to just dismiss at this time, and we just want to say that certainly you're welcome to come here at Shiloh anytime that you feel like you want to come. We have service each Sunday. Amen. On first and third at 9:30, and second and fourth at 11. But we're going to just close out with prayer at this time. Heavenly Father, we thank you, Lord, for this day. Thank you, Lord, for those who have come, those who have participated. Thank you for all that are under the sound of my voice. We thank you. We ask that you will continue to bless and protect them, Father, as only you know how. Now, Heavenly Father, as we prepare to leave this place, dismiss us from this place, but not from your presence. And as we journey back to our individual destinations, we pray for traveling mercy. These and all other needful blessings in Jesus' name. Amen. Amen. Amen.